Okay, so we are recording. All right, welcome everyone. This is going to be week 1, day 1 for the interpretive training for interpreting an outpatient mental health setting. So my name is Robert. I'm sure lots of you already know me. I am the recruiting and training coordinator for the International Institute of Buffalo. I work in the interpreting and translation department. I've been here about 4 years now, and I started as a Spanish to English interpreter. And yeah, what I work on now is I recruit interpreters that we need for certain languages, and I organize our monthly training calendar so that we can have events just like this. So if you wanted, Lynn, you can go to the next slide. All right. Not present, I assume, I think is also Emma Montague. She was the individual that we consulted with. She's a currently practicing mental health professional. She did some consulting and editing on the presentation. And then I'm going to turn it over to today's presenter.
All right. Hi, everyone. My name is Lynn. I'm a recent graduate from UB, and I interned at IB in the translation and interpreting department during the spring semester. As a part of my internship, I create this presentation and training, which is something I am really proud of and happy to be sharing with everyone today. I hope everyone will learn and gain a lot of new information about the subject of mental health, not only for interpreting, but as well as for yourself to be more aware of the importance of it. And just to note, I ask everyone to please bear with me since this is my first time doing this. I personally am not a trained mental health professional, so I haven't done or provided therapy or counseling myself, but I'm educated on the topic of it. But all the mental health related information provided was reviewed by Emma Montague, who is the mental health professional, as stated by Robert. But any information you may have during the presentation, I will answer them to the best of my ability. And any questions I cannot answer during the time, I will research and find more information on it to give you the proper answer later on. So again, I just want to thank everyone for coming today. So let's get started with the presentation. And just to note, this training will be recorded. So if you do not want to be recorded, please turn your camera off and mute your audio when you are not speaking.
All right. Also, if you wanted to go back just one moment, sorry about that. If anybody wanted to speak up and introduce themselves, feel free to do that. You can give your name, you can give your language, and maybe talk about if you have any experience with interpreting mental health, and where are you from, or where do you live now? So you can either do that in the chat, or you can unmute yourself and speak up if you wanted to say hello to the group.
Hello.
Hi there.
Hi, my name is Jimena. I am from Peru. I am a medical Spanish interpreter, and actually, this part of counseling and psychiatry, interpretation is what I like the most of medical, and I'm really excited for this training. And thank you very much for the opportunity. I'm sure this will be really great for everybody.
Thanks so much for joining, Jimena. And again,
Hi,
if anybody wanted... Oh, go ahead.
Oh, sorry. Hi, my name is Dua. I am from Djibouti. I am an asylee. I am a house manager at the Buffalo Peace House in Hamburg. And I am very glad and happy that Justice for Migrant Family gave me this opportunity to join you guys. And thank you for having me. And I will hope I will be able to become a good interpreter because of Lynn and yourself, Robert. Thank you so much.
Of course. Thank you for joining today.
Thank you.
Thank you.
Okay. And I see Ngarmbo, you're wanting to introduce yourself. Why don't you go ahead and unmute yourself? Because you're on mute, so nobody can hear you when you're speaking. Oh, it looks like you're still on mute, Ngarmbo. Did you want to just press the unmute button? It looks like a little microphone.
Yeah. Can you hear me?
Yep, we can hear you now.
Okay, my name is Gabo Mashtibai. I am originally from Chad, and I'm a former interpreter, international institute for close to 10 years. So now I'm coming back. I'm also a French teacher and substitute teacher. Thank you.
Yeah. Welcome, Ngarmbo. Thanks for coming today. Okay, I'm going to just put you back on mute there. Did anybody else want to speak up and say hello? Hi, Midori.
Hi. Hi. Hey, Robert. Hi, my name is Midori Fujiyama. I'm from originally Tokyo and now live in Buffalo. So I translate and interpret Japanese and English.
Welcome. Do you have any experience with interpreting for mental health, Midori?
No, but I'm interested. So
Okay.
Thank you for the opportunity.
Of course. Thanks for coming.
Thank you.
Hi, my name is Swan Mark. Can you hear me?
Yeah.
Yeah, can hear you.
Oh, okay. Because for some reason I cannot type. Yeah, my name is Swan Mark. I'm right now in BC, Canada, and Rob is very nice. Always send the information so I can participate. Yeah, I'm the interpreter between the Chinese and English. I had some mental health interpreting training 15 years ago. And right now I do quite a lot. It's a virtual interpreting, it's online and for the patients and the clinic, right? Doing the mental problem, yeah, and mental health problem, yeah, session. Thank you, yeah.
Thanks for coming, Swan.
Thank you.
Yeah, you're welcome.
Hi, my name is Alliance, and I'm so excited to be in this program. I haven't been an interpreter yet, but it's my interest to be an interpreter, especially for mental health. So I'm excited to be here. This is my first journey.
Awesome.
Thank you.
All right. So I think maybe that we can get started. So I'll let you take it from here, Lynn.
All right, so let's get started. I just want everyone to keep in mind that all of the information provided in this training session is only meant for the use of interpreting. So please do not use the information provided today to attempt to diagnose friends, family, or the people around you. This training is only to bring awareness to mental health for yourself and as well as for your role as an interpreter. So the topics we will be covering in this week are: what is mental health? Why is it important to take this training? Mental health illnesses and problems, specific definitions and symptoms, the vocabulary you may need to know that is related to mental health. And I also suggest for everyone to take a few notes, since there will be small quizzes to see if you've been paying attention. And please don't be afraid to speak up or type in the chat any questions you may have during the presentation, and I'll try to get to them as soon as possible. So I want to start off with discussion. So I want to ask everyone, what is your personal experience with mental health interpreting? I know we already talked about it, but if maybe you remember another experience, you can just bring it up, as well as what are some cultural attitudes or beliefs about therapy or counseling that is shared by the culture for your targeted language. And anyone can share as long as you're comfortable with it. I can start to give an icebreaker. So of course, I'm not an interpreter, but I have gone to counseling myself for mental health. regarding difficult emotions that I was going through from a personal situation and not understanding myself or what I was going through at the time. Especially as an Asian American, mental health and discussing emotions was not talked about in my household. So with many Asian households, therapy is not typically encouraged and emotions tend to be suppressed. So it can be a big step to decide to go to counseling and have a mental health professional help me get a better understanding of who I am and what I can do for myself to understand my emotional situation at the time. And personally, it really helped me understand many aspects of myself I didn't notice before, and I got to grow as an individual from the experience. So if anybody would like to share, I'll give the floor to anybody.
Hi, my name is Mane. I interpret from English to Turkish and Turkish to English. Before getting this training, actually a couple of years ago, I interpreted for a few number of patients at ECMC and in other facilities. Usually mental health is nothing that people want to talk about, but in many cultures, it is almost like a taboo.
Yes.
So it is very difficult for the patient or the patient relatives to understand the situation because it is not like getting surgery, any kind of other medical help from different doctors. So my experience was the patient and the patient relatives were having a hard time trying to understand the situation and then trying to disclose their innermost feelings
Right.
to total strangers. But then along the way, through therapy, people learn how to deal with the situation and understand that it's a human condition.
Yes.
So that was my experience. I just wanted to share that. Thanks.
Yeah. No, thank you so much for sharing. All right, is there anyone else that would like to share? If not, I will continue.
Sure, I can say a little bit. Oh, sorry, somebody want to?
Yeah, go.
Okay, yeah, just like what you said, this is very cultural things, right? For most of Chinese, normally, they can see the mental health like a shame, right? So normally they don't want to seek any help unless, right, very, very serious. So I'm very surprised actually in BC at least, seems more and more people come out because most are children, right? Probably because pandemic, right? Lots of a problem, and they came out seeking for the help. So that's why we are there, right? For the counseling or psychiatrist, right? The treatment. For our interpreters, one thing is we are getting very emotional when we do this kind of a session because so that is, I found it every time when I finish the mental health interpreting session, I getting like a cry or something like that, right? Just very depressed sometimes, right? So I think sometimes as an interpreter, we need help too. For our emotion part, because we always put ourselves in their shoes, right, in their position to share their emotion and the mood like that, right? So as interpreter, we need help too, and some way to help us to release our emotion too.
Which is what this training is all about. So just to go on into the training, we'll also be talking about things that will help you as an interpreter as well, and how to, it's natural as a human to be empathetic and compassionate, especially towards things that are more difficult in terms of mental health.
Yes, that's right. Yeah, thank you. Yeah, that's my sharing.
Right, thank you.
Thanks.
Okay, so I'll just go on next to our next section. So I'm going to talk about what is mental health. So by definition, mental health encompasses a person's psychological, emotional, and social well-being. And factors that contribute to mental health problems include the biological, which is the brain chemistry and genes, life experiences. There are two particular circumstances in regards to this, which include deeply personal experiences, which involve the influence of our family, our relationships, and how we see ourselves. And second is the social circumstances which we find ourselves in, whether it be poverty, violence, or employment. And lastly is family history, which is of our mental health problems or illnesses. So next, why is it important to take this training? So in regards to mental health interpreting, there are 5 reasons that stood out. 1, mental health interpreting increases access to care. So although interpreting for a medical healthcare setting is important and can save lives, it may be more important at times in a mental health setting, because in many cases, mental health patients don't have physical symptoms that can be independently measured. And to get access to care, patients have to be able to describe their emotional state, which can be difficult, even in your first language. 2, mental health interpreters help patients understand their treatments. So informed consent is one of the most important aspects of medical ethics. It's also a vital part of mental health care, especially when the treatments themselves can be distressing or traumatic for a patient. 3, mental health interpreting increases patient safety and compliance. Mental illness can lead to a lower quality of life. For some people, it can also lead to injury or death, whether through suicide, self-medication, or risky behavior, depending on the kind of mental illness that they may be going through. Communication barriers make it easier for patients to reach out and for clinicians to spot red flags before it's too late. So the interpreting services help bridge that gap so people get treatment when they need it. 4, mental health interpreters reduce the risk of misunderstanding and misdiagnosis. Interpreters interpret more than just the spoken words. They also translate differences between cultures, and these differences influence the way people talk about mental illness and describe their symptoms. In mental health care, these misdiagnoses can easily lead to misdiagnosis. 5, many cultures lack certain English mental health terms. So the vocabulary in different cultures to express mental health needs don't always exist in the same way it does in English. So in this case, interpreters can work with patients and their families to help explain concepts that they aren't familiar with. So in general, it may be difficult for interpreters to interpret a message for a client relating to mental health, because in therapy or counseling sessions, clients may speak for long periods of time while rambling and being incoherent in their speech. So clarification or repetition may not always be possible in a mental health setting because of a patient's condition or the fear of interrupting a patient's painful recollection of a traumatic event. So to be better prepared for interpreting in a mental health setting, interpreters should be educated on all things related to mental health. So right now, there is a lack of interpreters for mental health. And again, I want to emphasize how thankful I am of everyone willing to be here to learn, listen, and be more educated on the topic of mental health, and to have a awareness and be a part of the help of giving more accessibility to mental health treatments. So there's always been a stigma associated with mental health. Going to therapy or counseling and asking for help when needed, just as we have to go to a doctor's office to treat our physical injuries and sicknesses. Going to therapy and counseling for mental health is equally as important. So some of the more common reasons individuals may go to therapy or counseling include depression or anxiety, addiction, typically for alcohol or substance abuse, and many times these clients have these addictions as a way to distract from their troubles or suppress their emotions, and can sometimes be correlated with other mental illnesses. Behavioral control, stress, whether it's with daily life, work, or school, trauma, grief, whether it's loss of a loved one, loss of a relationship, or even loss of an individual self. Transitional change, adjustments in changing careers or transitioning from college into the work field. And therapy and counseling is also not only for the major or life-changing events, but also a place when people need guidance to understand themselves or feel stuck in life. So hence the self-awareness and personal growth. So next, we're going to talk about the mental health illnesses and problems. So the definitions that I'll be talking about today are more westernized definitions, so please keep that in mind, since every culture may define specific mental health illnesses or problems differently. Also, mental illness will look different for everyone, so keep your mind open and just be kind to one another, since we never know what someone is going through, and mental illnesses have various degrees of severity and symptoms, and which all are valid, and there is not one that is worse than the other. So mental illness is not a black or white subject, but rather a subject with a lot of gray area. So first we're going to talk about depression. Depression is a type of mood disorder characterized by low or irritable mood or loss of interest or pleasure in almost all activities over a period of time. So depression is a common mental disorder and one of the main causes of mental illnesses worldwide. Globally, an estimate about 264 million people are affected by depression. More women are affected than men. So symptoms for depression must last at least 2 weeks and must represent a change in the client's previous level of functioning for a diagnosis of depression. There can be mild or severe symptoms. So specific symptoms include feeling sad or having a depressed mood, loss of interest or pleasure in activities once enjoyed, changes in appetite, which can result in either weight loss or gain unrelated to dieting, trouble sleeping or sleeping too much, loss of energy or increased fatigue, increase in purposeless physical activity or slowed movements or speech, feeling worthlessness or guilty, difficult thinking, concentrating, making decisions, or thoughts of death or suicide. I'd also like to note that being sad is not the same as having depression. Being sad or grieving is natural and unique to each individual and shares some of the same features as depression. But to have a better understanding, I'll speak on specific comparisons in terms of grief. In grief, usually there are painful feelings that come in waves, often intermixed with positive memories of the deceased or what is lost, whereas major depression, mood, and or interests are decreased for most of the 2 weeks. In grief, self-esteem is usually maintained, whereas in major depression, feelings of worthlessness and self-loathing are common. And then in regards to grief of a deceased loved one, thoughts of death may surface when thinking about fantasizing about joining the deceased, whereas in major depression, thoughts may be focused on ending one's life due to feeling worthlessness or undeserving of living or being unable to cope with the pain of depression. Next is anxiety. So anxiety is the fearful anticipation of further danger or problems accompanied by an intense, unpleasant feeling or physical symptoms. Individuals have feelings of intense fear and distress become overwhelming and prevent those with anxiety from doing everyday activities. So the symptoms are broken down into 2 parts, emotional and physical. So emotional involves feelings of apprehension or dread, feeling tense or jumpy, restlessness or irritability, anticipating the worst. Physical can include pounding or racing heart and shortness of breath, sweating, tremors, headaches, fatigue, or even sometimes having an upset stomach. So there are 4 types of anxieties, one being generalized anxiety disorder, which is also GAD. It produces chronic, exaggerated worrying about everyday life. Social anxiety disorder, which is more than just shyness. This disorder causes intense fear about social interaction, often driven by irrational worries about humiliation. Panic disorder, which is characterized by panic attacks and sudden feelings of terror, sometimes striking repeatedly and without warning. Phobias, or an intense fear of something. We all tend to avoid certain things or situations that make us uncomfortable or even fearful, but a phobia is a fear of something that you cannot manage and affects your quality of life. So next we'll go on to bipolar disorder. So bipolar is a type of disorder with marked changes in mood between extreme elation or happiness and severe depression. So people with bipolar experience high and low moods known as mania and depression. Bipolar is more than just mood swings. This is a common misconception. In order to manage bipolar, medication is necessary. So the symptoms involved with bipolar usually involved a distinct manic or depressed state. Severe bipolar episodes of mania or depression may include psychotic symptoms such as hallucinations or delusions. And usually these psychotic symptoms mirror the individual's extreme mood. And the signs of mania in bipolar disorder include feeling overly happy or high for long periods of time, having a decreased need for sleep, talking very fast, often with racing thoughts, feeling extremely restless or impulsive, becoming easily distracted, having overconfidence in your abilities, or engaging in risky behaviors such as having impulsive sex, gambling with life savings, or going on big spending sprees. The episodes of mania must last for 4 more days, and briefer manic symptoms are typically trauma or personality disorder related. And in regards to a manic episode, it is more than just the feeling of elation, high energy, or being distracted. During a manic episode, the mania is so intense that it can interfere with an individual's daily activities, and it's difficult to redirect someone in a manic episode towards a calmer, more reasonable state. So many times individuals with bipolar disorder who have psychotic symptoms can also be wrongfully diagnosed as having schizophrenia. So individuals may also have extended periods or sometimes years without symptoms as well. So there are 2 different types of bipolar disorder, bipolar 1 and bipolar 2, and the difference between is the severity of the manic episodes caused by each type. So bipolar 1 is having at least experienced 1 full manic episode, or as well as may or may have not experienced a major depressive episode. Bipolar 2 involves a major depressive episode lasting at least 2 weeks and at least 1 hypomanic episode, which is a period that's less severe than a full-blown manic episode. But people with bipolar 2 typically don't experience manic episodes intense enough to require hospitalization. And because of the depressive episodes, it can sometimes be misdiagnosed as depression. So when there are no manic episodes to suggest bipolar disorder, the depressive symptoms become the focus. Right, next, we are going to talk about borderline personality disorder, also known as BPD. So people who experience BPD feel emotions intensely and for long periods of time. It leads to impulsivity, poor self-image, stormy relationships, and intense emotional responses to stressors. So usually struggling with self-regulation can also result in dangerous behaviors such as self-harm. And in clinical settings, BPD is very common and is very stigmatized. Many patients with BPD have come from families that were abusive or neglectful, and that there's also a strong genetic foundation for it. So the symptoms that are involved with BPD include frantic efforts to avoid real or imagined abandonment by friends and family, unstable personal relationships that alternate between idealization, such as being like, oh, I'm so in love, or devaluation, such as, oh, I hate her. This is also sometimes known as splitting, distorted and unstable self-image, which can affect the moods, values, opinions, goals, and relationships. Impulsive behaviors that can have dangerous outcomes, such as excessive spending, unsafe sex, reckless driving, or misuse of substances. Self-harming behaviors, including suicidal threats or attempts, periods of intense depressed moods, irritability, or anxiety, chronic feelings of boredom or emptiness, inappropriate, intense, or uncontrollable anger, as well as dissociative feelings, disconnecting from thoughts or sense of identity or out-of-body type of experiences, and stress-related paranoid thoughts. So after explaining the symptoms of BPD, I know it sounds similar to bipolar since both are characterized by mood instability and impulsive behavior, but they differ in one quality. While the disorders are both characterized by mood changes, the quality of the mood changes can be very different. So people with bipolar disorder tend to experience mania and depression, whereas people with BPD experience intense emotional pain and feelings of emptiness, desperation, anger, hopelessness, and loneliness. 2, time. In BPD, mood changes are often more short-lived. They may last for only a few hours at a time. In contrast, mood changes in bipolar tend to last for days or even weeks. 3 is cause. Mood shifts in BPD are usually in reaction to an environmental stressor, such as an argument with a loved one, whereas mood shifts in bipolar disorder may occur out of the blue. And lastly, 4, the mood shifts typical of BPD rarely involve elation, and usually the shift is from feeling upset to feeling okay, whereas feeling bad to feeling in an elevated mood is more typical of bipolar. All right, next is schizophrenia. So schizophrenia is the interference with a person's ability to think clearly, manage emotions, make decisions, and relate to others. Schizophrenia is complex and may help explain why there are so many misconceptions about it, but schizophrenia does not mean split personality or multiple personality. So to reiterate from the previous BPD slide, schizophrenia may have a genetic foundation according to emerging research, as do most mental illnesses. A person with schizophrenia will experience 2 or more psychotic symptoms, such as delusions, which are false beliefs, disorganized speech, hallucinations involving hearing or seeing things are not there, negative symptoms, and catatonia, or other markedly abnormal behavior. And I'll explain more about the symptoms in the next slide. Schizophrenia, again, is highly stigmatized diagnosis. It's important to remember that many people with schizophrenia are able to live satisfying lives as long as they take their medication. The severity of schizophrenia symptoms depend on whether they are medication adherent. So taking that into account, about 70% of individuals with schizophrenia have anastomose, and meaning that they do not know that they are ill. This accounts for a large number of schizophrenic patients who are not medication adherent. So the symptoms involved with schizophrenia usually have to be present for at least 6 months. So one is hallucinations, and this includes a person hearing voices or seeing things, delusions, false beliefs, such as paranoia, a belief others are out to get you, romantic delusions in case of a belief that someone is in love with you, negative symptoms in which that diminishes a person's abilities, and negative symptoms often include being emotionally flat or speaking in a dull or disconnected way. People with the negative symptoms may be unable to start or follow through with activities, show little interest in life, or sustain relationships. And within these negative symptoms, there is catatonic schizophrenia. And this is when an individual meets the criteria for a diagnosis of schizophrenia and also exhibits symptoms of catatonia, which is not moving, not talking, sluggish responses, parroting someone's movements or speech over and over, or tapping the feet or other repeated movements. Yes, Jennifer, you can ask a question in the chat. And also, catatonia affects both speech and behavior and is defined by excessive movement or decreased movement. And lastly is cognitive issues and disorganized thinking, which is people with cognitive symptoms of schizophrenia often struggle to remember things, organize their thoughts, or complete tasks. And the severity of a person's schizophrenia will depend on the amount, frequency, and severity of each of these symptoms. So just to note, people who experience these psychotic symptoms can also exist without a schizophrenia diagnosis, for example, due to a medical condition such as a UTI. Next, we have ADHD, also known as attention deficit hyperactivity disorder, and is one of the most common neurodevelopmental disorders of childhood. It is usually first diagnosed in childhood and often lasts into adulthood. Children with ADHD have trouble paying attention, controlling impulsive behaviors, or be overly active, and are typically diagnosed during childhood, but can be diagnosed in adulthood too. I saw a question.
Yeah, Claudia was asking that she heard that some people with schizophrenia are violent with others around them. Is this true?
No, that is not true. As long as they're on their medication, they can become less not as violent, but we shouldn't refer to those who are diagnosed with schizophrenia to be violent, because as long as they're on their medication, they can still live a very normal life. Does that answer your question?
Yes, she said thank you.
Yes, okay. If there's anything else that you would like me to research more about, I can also ask our mental health professional, Emma Montague, more about it if there's something that I cannot answer completely. Okay, so continuing on with ADHD. So the symptoms, behaviors associated with ADHD are normal and are not a cause for concern for most people, but someone with ADHD will have trouble controlling these behaviors and will show much more frequent and longer symptoms for 6 months. And symptoms are in 3 parts: the inattention, hyperactivity, and impulsivity. So signs of inattention include becoming easily distracted and jumping from activity to activity, becoming bored with a task easily, or difficulty focusing attention or completing a single task or activity, not listening or paying attention when being spoken to, or difficulty processing information quickly. Signs of hyperactivity include fidgeting and squirming or having trouble sitting still, nonstop talking, or difficulty doing quiet tasks or activities. And then impulsivity may include impatience, acting without regards for consequences, blurting things out, or interrupting others. Next, we'll move on to PTSD. So PTSD is a response to a traumatic event that causes lasting emotional or other problems for a person, and typically involves intense anxiety and avoidance of feared stimuli. So these traumatic examples may include a natural disaster, a serious accident, war or combat, a rape, sexual violence, or serious injury. To be more specific, a person who witnesses violence may not like being around large groups of people for the fear that things could get out of control. And also, everyone reacts to trauma differently, including their physical and emotional reactions. So there is no right or wrong way to think, feel, or respond. So it's important to not judge your own reactions or other people's reactions towards a person's trauma. So symptoms regarding PTSD include re-experiencing type symptoms, which are reoccurring involuntary and intrusive distressing memories, such as flashbacks of the trauma, bad dreams, and intrusive thoughts. Avoidance, staying away from certain places or objects that are reminders of the traumatic event. A person might actively avoid a place or person that might activate overwhelming symptoms. Cognitive and mood symptoms, which involve trouble recalling the event, negative thoughts about oneself. A person may also feel numb, guilty, worried, or depressed, and have difficulty remembering the traumatic event. And typically, cognitive symptoms can, in some instances, extend to include out-of-body experiences or feelings that the world is not real, also known as derealization. And lastly is arousal symptoms such as hypervigilance, which examples might include being intensely startled by stimuli that resembles the trauma, trouble sleeping, or outbursts of anger. So those with PTSD may also experience dissociation, which is caused by extreme trauma, which some immigrants and refugees do have. So dissociation is characterized by an involuntary escape from reality, characterized by a disconnection between thoughts, identity, consciousness, and memory. And people with trauma may use dissociation as a coping skill to turn off their brain during stress. And almost everyone dissociates at times, such as when we're driving somewhere and can't remember to recall the car trip. But it becomes harmful when a person does not remember that significant stretch of time or important events and feels out of control of their dissociation. Next, we have OCD, also known as obsessive compulsive disorder. So this disorder is which people have reoccurring unwanted thoughts, ideas, or sensations that make them feel driven to do something repetitive. The symptoms usually include obsessions that are recurrent and persistent thoughts, impulses, or images that cause distressing emotions such as anxiety or disgust. Some specific examples can include fear of getting contaminated by people or in the environment, disturbing sexual thoughts or images, fear of blurting out obscenities or insults, extreme concerns with order, symmetry, or precision. And also there are compulsions or repetitive acts that are temporarily relieve the stress brought on by an obsession. Specific examples include excessive or ritualized hand washing, showering, brushing teeth, or toileting, repeating cleaning of household objects, ordering or arranging things in a particular way, or repeatedly checking locks, switches, or appliances. So next we have ASD, which is also known as autism spectrum disorder, which is a developmental condition that affects a person's ability to socialize and communicate with others. People with ASD can present with restricted and or repetitive patterns of behaviors, interests, or activities. Symptoms of ASD often start to appear during the first 3 years of life. So symptoms usually involve delay in language development, such as not responding to their own name or speaking only in single words, if at all. Difficulty making eye contact, such as focusing on a person's mouth when they are speaking instead of their eyes, as usual in most children. Difficulty interpreting subtle gestures and facial expressions, such as misreading or not noticing a subtle facial cue like a smile, wink, or grimace that could help understand the nuance of a social communication. Problems in expressing emotions such as facial expressions, movements, tone of voice, and gestures that are often vague or do not match what is said or felt. And lastly, a lack of social understanding that makes interactions with peers challenging. So next is eating disorders. So eating disorders are illnesses in which people experience severe disturbances in their eating behaviors and related thoughts and emotions. People with eating disorders typically become preoccupied with food and their body weight. So there are 3 common types of eating disorders, one being anorexia nervosa. So people with anorexia will deny themselves food to the point of self-starvation as they obsess over weight loss. They typically deny hunger and refuse to eat, practice binge eating and purging behaviors, exercise to the point of exhaustion as they attempt to limit, eliminate, or burn calories, fear of eating in public, obsession with food and exercise, and also have very low food intake and inadequate nutrition that causes a person to become very thin. Next is bulimia nervosa. So that is binging on very large amounts of food during short periods of time and then desperately trying to rid themselves of the extra calories using forced vomiting, abusing laxatives, or excessive exercise. It is typically a repeated cycle that controls many aspects of a person's life and has very negative effects that are both emotional and physical. People living with bulimia are usually normal weight or even a bit overweight, and the binging and purging can severely harm the parts of the body involved in eating and digesting food. Teeth are usually damaged by frequent vomiting and from the acid reflux. And lastly is binge eating disorder, which is losing control over eating large amounts of food in a short period of time, and eating large amounts of food even when an individual isn't hungry or after one is uncomfortably full. So also just to know, even though an individual may look like they are associated with one of these kinds of eating disorders, keep in mind that there may be other reasons an individual may have lost or gained weight unrelated to dieting, such as having depression, illness, anxiety, loss of a loved one, or even a broken heart. So next we have gender dysphoria, which is also called gender identity conflict. So this is a psychological distress that stems from the way an individual feels or thinks of themselves being in contrast to their physical gender. Individuals who experience gender dysphoria feel this distress often at an early age, but sometimes not until puberty or later. So just to keep in mind, although those who are transgender typically experience gender dysphoria, being transgender does not mean someone is experiencing gender dysphoria, and experiencing gender dysphoria does not mean someone is transgender. All right, so now we're gonna take a break. I know that was a lot to take in. So just take the 15 minutes to just go to the bathroom, eat a snack, or just to intake all the information that was just thrown at you. I'll put a timer up for the 15 minutes.
And you can go ahead and leave the meeting open. Just, put your device on a charger, perhaps, and I'll stop recording while we're on break. I'm actually going to leave it up. Sorry for the confusion.
Oh, the presentation?
The recording, sorry.
Because I put a timer up for the presentation. All right, is everybody back?
Yes.
Yes.
All set.
Yes.
Right, shall I continue?
Yes.
Let's go.
Yes, I'm back.
Okay, good.
I missed the most part of the class, but I am here.
Okay. It's okay, as long as you're here. There will be recordings that will be sent out as well as the presentation.
Oh, that's great. Yeah, we like to get some presentation. Yeah.
Oh, of course, there's a lot of information that I just talked about. So
Yeah, that's right. Yeah, thank you.
if there's any other questions, if anybody wants to ask any, I can answer them before I get to the quiz. Yeah.
I have a question about gender dysphoria, ASD, and ADHD, classified as mental illness, not like developmental disabilities or what else. You know, like when child has like ADHD, I thought it's more like developmental disabilities.
It's more of a neural developmental disability. So it still refers to mentally, but it is more neurological. So like the brain chemistry, and it still technically is.
So technically it's mental illness?
Well, I would say more of it's a mental health problem. I can look more into it and I can tell you next week because
okay.
Sure. Yeah.
Thank you. One more thing, gender dysphoria, is it mental illness? You know, I thought these days people don't, you know, say that.
Well, it can affect themselves mentally.
It can affect your mental health and cause, there can be resulting mental health issues. For example, if you have, intense gender dysphoria, it could cause intense depression or anxiety. And just like with ADHD, the ADHD itself is not a mental illness, but often it can, as a result of the person suffering from the symptoms, those can cause mental, like anxiety or depression.
Okay, so it's more like mental health issues, but not mental illness.
No.
Okay, thank you.
Are there any other questions?
I have a question that depression will be effect on mental health if someone has depression.
I'm sorry.
It will be because of the mental health.
Can you please repeat the question?
Depression is, if depression is yet worse, it will be changed to the mental health situation or no? Mental health issues?
Like, will it get worse, essentially?
Yeah.
Yeah, it can get worse.
I'm really worried about myself because I'm so depressed. I have many challenges here. That's why I don't know how to control myself.
Oh, okay. Well, what have you personally done for yourself in terms for feeling depressed? Have you thought of asking for help and of seeking therapy?
Not yet, but I try to keep myself busy with work, with class, with something. It suddenly get worse.
Because that is very common for those, since again, mental health is stigmatized, and sometimes we believe that we can figure things out by ourselves and think that we are capable of going through it by ourselves. But I want you to know that it is very important that if it's getting to a point that you don't know how to handle it anymore, it is very important that you ask for help, because it is very, very important. Mental health, again, is very, very important. So if you are feeling this way and you feel like you can't do anything for yourself anymore, please go to your provider, even if it's your primary care physician, and talk with them about how you're feeling, and then they can also help you to guide on what to do next, especially if you're in need of therapy or medication.
One of the serious things that I face with here with insurance, I really scared. I don't want to go to see the doctor because when I go to see the doctor, I receive many bills and I'm not able to pay that. That's why I try to be away from doctor, from medicine, from everything. I have insurance, but it's not cover anything. That's why it's really hard.
Right, yes. That's actually something that I was going to talk about actually in my next slides, that a lot of insurances don't completely cover or even cover at all therapy or mental related treatments. And so I understand why you're feeling distress. If anything, I'll look more into if there's any areas around Buffalo that offer any free therapy or counseling. I'll look in more in that for you, and I can tell you as soon as possible, if anything. Because I understand that therapy is not always covered, and just mental health treatments in general are not. So I understand.
Even primary health care, it's not covered the primary. I went to just for the chest X-ray. I had a problem with my stomach. After that I received a lot of bill. That's why the people are suffering a lot because of the insurance. Nobody is able to handle it.
No, of course, yeah.
Especially for me, I'm alone here. I don't have any supporter. It's really hard time.
Yeah, the insurance can be really hard to navigate, especially when it's a foreign system.
Right.
So maybe it's possible we could even figure out a way to link you up with a caseworker who can figure out maybe some free therapy resources or free medical resources in the area so that you don't have to worry about health insurance or bills.
Yeah.
So yeah, we'll take a look at that when we're done with the training and get back to you, Ziba. Thanks for speaking up and having the courage to discuss.
Thank you so much. I was able to solve the many thousand of people problem, but now I am facing with many challenges. I can't find my way how to solve all these serious challenges.
Well, you're not alone.
Yeah, not alone, Ziva. And it's okay that you're expressing and having, again, Robert said, expressing how you're feeling right now, because it is very important that you're talking about it, because it is serious and it's something that not everybody completely understands. So thank you for sharing. And all of your feelings and however you're feeling right now is completely valid. So please don't feel afraid or feel like you're being judged.
You are welcome. Thank you so much. I'm very glad to have this class.
Yeah, I hope that anybody who feels any mentally distressed or anything to share, everybody here, I'm sure is, if you're here in this class, you're willing to be able to be open-minded and understanding of each other. So if anything, we're all here for you and understand.
Well, thank you, Ziba. We want to make sure that other people have some time to talk. So Ziba, if you want to talk some more, we can come back a little bit later. But I see Ngarmbo has his hand raised and wanted to maybe speak up and say something. So Ngarmbo, if you want to go ahead and unmute yourself, and then we'll be able to hear you.
It's okay. Thank you. Now you can continue the lecture, I'm willing to hear all these important sessions.
Thank you. Go ahead and Gambo.
Yes, I would like to ask one question about schizophrenia. Schizophrenia, the symptom, one of the symptoms is the cognitive issue. I would like to know if someone who got the schizophrenia can study normally, because sometimes we have disordered thinking and sometimes it's normal. So does this person can study at school, like children, adult?
Again, this is why medication is very, very important. That's why I emphasized it quite a bit. And from what Emma told us, she said that medication, those with schizophrenia can live a normal life as long as they're medication adherent. So as long as they're taking their medication, they should be able to live normally and without any problems as long as they're medicated, and along with therapy as well.
Thank you. Thank you so much.
Yeah, of course. Sierra, do you have a question?
Hi, Ellen. Thank you for this informative and very helpful presentation. And I just was curious about the phobias and how do these fall into mental health illness, if I should say. And I mean, is there something we can do to take care of it? I do myself have few of them, but I did not think of them as mental illness necessarily. And now that I've been, attending a lot of webinars, workshops, I do recognize that it is. And if you can touch on it, please.
Yeah, of course.
Thank you so much.
Yeah, of course. So just in general, like I said in the beginning of the presentation, this is mental illnesses, but also problems. So some of these don't necessarily are mental illnesses, but they affect your mental health and how you're feeling about what's going on. So with phobias, I'll talk about it actually next week on how those with phobias go to therapy to help with the fear of phobias or OCD, which is the type of psychotherapy counseling. So you have to wait until next week so I can discuss more about that. But like it's okay if you have those phobias, because it comes to a point where it affects the quality of life. So it's like there's things that a lot of us can be fearful of. Like we can be fearful of spiders or snakes or heights. Those are common, but sometimes the phobias, it gets to become a phobia when you can't enjoy your life anymore, and it affects how you go out about life. Like you can't do certain things, or you can't go out, or you get to a point where it might, if you're so scared of a certain phobia that you shake, or you can't handle it, or it's heart racing, similar to anxiety. So like it can cause anxiety because of the phobia. Does that help?
Yes, absolutely. Thank you so much.
Okay. Again, if there's anything else that, if you're not sure about it, and I can't answer it completely, again, I can ask our mental health professional to clarify anything, or I'll do more research.
Okay, thank you.
Hi, this is Dua. I have a question, if you don't mind, Lynn.
Of course, no, I'll answer.
Yeah, thank you so much. Actually, since the beginning of this training, I was listening, and the title of this training is, interpreting for mental health outpatients, right?
Yeah.
So actually, we are learning so many technical words, concerning the mental health. And my question is, this training, is it for the clients or is it for us, who are participating this training?
This is, yes, this is for the interpreters, but also for the clients in the case that it helps you help the clients better. So as you're learning and getting more information and educating yourself more about mental health, you're helping and being more understanding and becoming more aware for whoever you will be interpreting for in a mental health setting.
Okay, so my other question is, what if one of the interpreter went through, trauma? Because you know that most of us are refugee or asylee, so means that there is equal to trauma and PTSD and so on. So don't you think that it will be a little bit sensitive for us to interpret for mental health outpatients? And how can we protect ourselves without being involved, without being, getting sentimental while interpreting for those, for our clients?
Of course. Robert, if you want to answer, but actually I'll talk more about this. All these are such good questions. I will talk about them more in also the next week and the upcoming weeks actually about it. But if Robert, if you'd like to say anything more.
Of course.
Yeah.
So it obviously takes, some exposure and practice to be able to really learn how to compose yourself and not feel overwhelmed by those situations. But another thing to consider is that depending on the place you work for example, if you're an independent contractor as an interpreter, you're never obligated to take certain kinds of jobs or appointments. You might work in a place where you're a full employee and the work is what it is and you have to interpret where you have to interpret. But if you find that you may never be at a place where interpreting for these kinds of situations is something you'll ever be comfortable with, then it's just something that you would have to disclose to your employer or the agency that you work with. But there are, self-care techniques and mindfulness techniques that help you to kind of stay present. And of course, they're not always going to work 100%, but it's something that even people who haven't experienced this, the same kinds of trauma, they risk, secondhand trauma, or they risk being strongly affected by it. So, it is something that in the end, you choose or choose not to do it. And, nobody ultimately can make you interpret in these settings, but hopefully after taking a training like this, you might have some skills to help yourself perform a little bit better in mental health settings.
Thank you so much.
Christina, do you have a question?
Sorry, my mic was mute. Yes, hi, this is Christina. As what Robert was saying and what Jennifer, this is so true. I'm work in mental health in a mental hospital, which is those hospitals who take care of these people who commit a crime, but they don't know because they are, mentally ill. So they don't know about the crime. And I have a family member who was in jail. So going into this particular, building, to me, took me like 2 days just to cross the door. So this can be like Robert says, like a secondhand trauma, because it's like you are feeling everything again in there, and you are helping people, yes, but it's like can be so challenged if you have a case in the family or yourself. So yeah, it's totally agree with them.
Thank you for sharing.
Okay, so I think now would be a good point to move on from this topic. If anybody else had some questions, go ahead and use the chat and put them in there, or maybe we can save them for later at the end of the training or when we reach another topic.
Yes, and thank you for everyone for sharing and just talking about your points of view. Really appreciate it. We can all learn from each other. Okay, so moving on. So I have quizzes just to see if everyone was paying attention. So for the first quiz, you can just either unmute yourself or just answer in the chat. What mental illness interferes with a person's ability to think clearly, manage emotions, make decisions, and relate to others? It is severe and a persistent mental illness which requires medication.
Don't worry about being wrong.
Yes, it's okay.
Is it schizophrenia?
Yes, that is correct. It is schizophrenia. So again, schizophrenia is a highly stigmatized diagnosis. It's important to remember that there are many people with schizophrenia who are still able to live satisfying lives as long as they take their medication. So quiz 2, which disorder or problem displays the following symptoms? Distinct manic state, distinct depressed state, hallucinations, and delusions.
Bipolar?
Yes, you got that correct. It is bipolar. So again, bipolar and BPD may get confusing with one another. So again, the differences are from their quality, time, cause, and degree. I'll just reiterate them. For quality, people with bipolar disorder tend to experience mania and depression, whereas people with BPD experience intense emotional pain and feelings of emptiness, desperation, anger, hopelessness, and loneliness. 2 is time. In BPD, mood changes are often more short-lived and they may last for only a few hours at a time. And mood changes in bipolar disorder tend to last for days or even weeks. Causes, mood shifts in BPD are usually in reaction to an environmental stressor, such as an argument with a loved one, whereas a mood shift in bipolar disorder may occur out of the blue. And then 4th is the degree, whereas the mood shifts typical of BPD rarely involve elation. And usually the shift is from feeling upset to feeling okay, whereas feeling bad to feeling in an elevated mood is more typical of bipolar disorder. All right, so this is just the last quiz. It's a little bit longer, but which of the following is not a symptom of ADHD? Looks like Mark got it right. Yes, it is D. Yes.
D.
Yep. Yep. So D for the delay in language development, as not responding to your own name or speaking only in a single word, if at all, is a symptom of ASD. All right. So now we're going to move on to vocabulary associated with mental health. So many of the mental health terminology terms will be possibly used in the mental health setting. So I want everybody to think about how you would possibly translate these words into your targeted language. So first is anashanosha, is when someone rejects a diagnosis of mental illness. So sometimes it may be tempting for an individual to say that a patient or client is in denial, but someone with acute mental illness may not be thinking clearly enough to consciously choose denial, and they may instead be experiencing lack of insight or lack of awareness. And a majority of anashanosha is common in schizophrenia and about 40 to 50% of bipolar disorder. So next we have is risk of suicide, which is suicidal thoughts often accompanying mental illness. Not taking these kinds of thoughts seriously can have devastating outcomes, and suicide can be prevented. So here are just a few warning signs of suicide. Usually there's maybe increase of alcohol or drug use, aggressive behavior, withdrawal from friends, family, and community, dramatic mood swings, impulsive or reckless behavior. So personally, what I've learned and gained perspective on the topic of suicide. Sierra, do you have a question?
Yes, actually, if I may. So how can you differentiate between someone who just throwing the word, I'm going to kill myself when they are upset or something, with someone who really has those thoughts? And so what's that fine line where you say, okay, you know, this is suicidal thoughts, whereas the other one is just like saying it's just, I don't know why. But
no, right, yeah. The term, I understand that sometimes that phrase, like, I'm going to kill myself, sometimes it can be used almost too leniently when there are other cases of individuals who really are at a risk of suicide. And I think that it depends on also the severity and how long that individual may have been experiencing it. So that's why it's important for also us, those who are at risk of suicide sometimes can hide it very, very well, that we may not even know that they are suicidal, which is why it's important, again, that we're aware of how we can prevent those who are at risk of suicide and to bring more awareness on the topic of suicide, which is why I'm actually about to talk about it more in what I'm about to say. But it really, yes, depends on how our job as like a human being and really seeing and understanding others. Yeah, essentially. Here, let me just talk about it more in mind, and then maybe that'll answer your question, if that's okay.
Can I add something to this
Yeah.
topic?
Yeah, of course. Yeah.
If we're wearing our interpreter hat, and if we're a liaison between a client and a patient or vice versa, if someone says like, I'm going to kill myself, our job is to interpret everything into the other language without any judgment or thought behind it.
Yes.
But if you're hearing this from our environment, like our loved ones or people in our families and stuff, then we're wearing a different hat, and then we might do everything to get help for them. If this is just like a whim to say it in a setting, or if it is a repeated saying, or if it is a mood that is lingering all the time. So I think there are two different ways of reacting to these kind of questions, depending on what we're doing in that moment. Like, who are we in that moment? That's what I think. I just wanted to add that. Thanks.
No, of course. Yeah, that makes a lot of sense. Yes. Yeah. Is there any other questions? I'll continue, and if there's any other questions, I'll again try my best to answer them. So again, what I've learned and gained perspective on the topic of suicide is that it is a public health concern, and suicide is the second leading cause of death in the world for those ages 15 to 24 years old. And since suicide is mostly linked with depression, 80 to 90% of people that seek treatment for depression are treated successfully using therapy and or medication. So something society needs to get a hold of that is a person who is suicidal is not in the right mind space. So going back to the stigma behind mental health, if mental health was seen as important as our physical health, then the choice of suicide wouldn't be as much of an option, since suicide feels like the only option for those who are not in the right state of mind. From the perspective of some non-suicidal individuals, they may see suicide as a selfish act or a way of getting attention, but that's far from the perspective of an individual who is suicidal. From the mind of a suicidal individual, it is seen as the only way to end their emotional pain. And even if they do have people who care for them, in their minds, they don't believe that's the case. So they feel like the world would be better if they weren't in it. And what a suicidal individual is thinking at the time is actually quite different from selfishness. And their idea is more along the lines of, my death will be worth more than my life to others. And although suicide is preventable, gatekeeping is an issue, as we talked about before, that interferes with the prevention since it keeps vulnerable people from getting the care and treatment they need. Again, therapy is a hard care to get and doesn't get covered completely or at all by insurance. And this is important. This is an important example of the many restrictions to things that essentially help our communities and society as a whole. But there's a lot of things where we question why things are wrong with society or why certain things are the way they are when there are clear solutions, yet certain things like gatekeeping for like health insurance prevent or exclude the most important needs, such as mental health care and treatments for those who need it the most. And at the end of the day, if we help each other, we help society as a whole. So the topic of suicide in general just needs more awareness, and it's important to note that those who are suicidal just need someone to listen to them. Talking about suicide with someone will not make them suicidal. In reality, talking about it typically makes a suicidal individual feel better because it gives the person an opportunity to address it, problem solve, and to feel better. And suicide comes with psychological pain, and that pain is as real as the physical. So compassion, understanding, and empathy is really important with mental health. And those who are suicidal are told many times that the main reason they shouldn't kill themselves is because of how it might affect others. Suicidal individuals deserve the love, help, support, and not guilt trips. They deserve to feel like that their life is worth living for themselves. So if it's ever needed, Robert and I provided sources for suicide prevention for yourself or anyone you think may need it. So I don't know if that answered the previous question that was asked, but I think it's more,
Yes,
mostly it's bringing awareness to it and talking about it and not making it as much of a taboo subject, essentially. Okay, so this is a video I watched in class while in school that does a pretty good job at explaining the importance of mental health and suicide.
I was barely a teenager.
Can everyone hear
I
okay?
tried to kill myself. If I knew then what I know now, well, it probably wouldn't have changed very much. And it probably wouldn't have changed very much because sometimes it doesn't matter what you know, what you feel just takes over. And there's so many ways like this that our perception becomes limited. In fact, our perception is its limits. And these limits, they're created by our biology, by our psychology, by our society. These are the factors which create that bubble which surrounds us, that is our perceptual field, our world as we know it. Now, this bubble, our perceptual field, it has this incredible ability to expand and to contract based on changes in any of those factors which create and inform it. Most of us have experienced the challenges of the contraction of our perception from time to time. Think about that time when you got cut off in traffic. In the city, it was probably today, let's face it. When it happened,
It looks like we may have lost some audio here.
Everything to go through your mind at that time was how creative you could be in the words you were about to hurl out the window at that guy. Now, eventually, your perception would have returned to normal. You would have relaxed, you would have went on with your day, you probably would have even forgotten about it. But imagine you didn't. Imagine you stayed there, stuck there, in that narrow, dark place. Well, that's what it can be like to live with a mental illness. At least that's what it was like for me at the depth of my own mental illness as a teenager. My perception had become constricted and darkened and collapsed. I felt like an asthmatic who had lost his glasses in a hurricane. So when I was sitting in that chair, across from my 8th grade guidance counselor, the only thing that I could think was, you're not good enough. You're not smart enough. You're not enough. And it didn't matter if I was, because these were the constricted limits of my perception. So when I held that 8-inch chef's knife in my hand, and I raised it to my throat, and I pressed it there, and I felt the blood begin to trickle down my hand, the only thing I could think in that moment, nobody would even know you're gone. I heard the guidance counselor ask from across the room, miles away it seemed like. He said, "Mark, please don't." I heard him, but I wasn't listening. I just took a deep breath. I don't have a choice. Had the guidance counselor not reached for me across the room, tackled me to the floor, wrestled that knife from my hand, maybe I wouldn't be here today. I think about that a lot. Now, not all days were that dramatic. In fact, most days I probably seem like just any other normal kid, if not a little quiet. And because the truth is, I was. In fact, I was so normal, most people never would have guessed. They probably would have even been surprised to find out how I would hate the way the sunlight came in my window every morning when I would wake up. And I know that some of you know that feeling too. I was so normal that a few years later, after not getting the help that I so clearly needed, most people would have never known that I was the one that had caused so much commotion late one night when I tried to jump from an overpass. Then again, if they did know, I would have been the last to find out anyway. Because that's how these types of things go. People seem plenty eager to talk about mental illness and about suicide, just as long as it's behind closed doors and in hushed voices. Well, this is the part that I'm doing differently with you today. By sharing with you my experiences, I hope to raise my voice, and I hope to open those doors. And this is how I do it. I remember I was wandering the empty streets of my hometown. I was alone this time, unlike that other time. And it's because I wanted to die alone. My mind was running, screaming, shaking, collapsing in on itself again. When you're in that place and your perception is collapsing like that, those old thoughts kept coming back again. You're not good enough. You're not smart enough. You're not enough. So I walked up and I approached the railing to the overpass. I walked along it. I looked over. I came to a light post on my left-hand side and I stopped. Should I hang in there for just one more day? That's a phrase that people always seem to ask themselves when they're suicidal, I've found. I asked it to myself and others with whom I've worked, young people today, they've asked it too. It's this instinctual word of hope. Should I hang on there for just one more day? For what? To be that crazy kid? I've already held on for this long and things haven't gotten any better. Why would I keep trying what hasn't been working? Not crazy. My perception was collapsing. It was squeezing out that instinctual hope that everybody has inside them. So I climbed the railing in 3 parts, like rungs on a ladder. I was being very careful not to slip. I climbed back down the other side again. I had very few choices in my life. But this was certainly one. And I needed something, anything that I could be certain about. So I turned around. And I felt the railing pressing against my back just below my shoulder blades. I stretched my arms out on its cool metal surface. I remember feeling raindrops under my fingers. I looked down at my shoes. My running shoes were old, worn out, tired. My heels were on the concrete. My toes were on nothing. I looked past my toes to the ground 50 or so feet below. And on the ground I saw a rusted out chain link fence topped by 3 strings of barbed wire. As I was standing there in that moment, the only thing that I could think from my collapsed perception was, how far out would I need to jump from this bridge so I wouldn't land on that fence? Because I just didn't want it to hurt anymore. In that moment, my entire life was completely in my control. And when you're living in a hurricane like this all the time, that's a really unfamiliar but really satisfying feeling, to feel like you have control over your whole life. So I stayed like that for a while. I just stood there in that feeling, experiencing that feeling of having agency over my life for a change. Eventually, I was brought back into the present by a man's voice over my right shoulder. I talked to him for a while, but even today, I don't remember about what. He was wearing a light brown jacket, but I don't remember his face. I didn't look back long enough, and I never saw him again. Before I knew it, I could see flashing lights from the corner of my eyes. I looked to my right and to my left, and there were 3 police cars on either side blocking off the street. There were crowds of late-night gatherers gawking at me from either side. This was 2, 3 in the morning, I guess. Either they came home from the bars or they just walked up to see what was going on. A male voice from my right side, I heard him scream to me, "Jump, you coward!" Okay, that's enough. Again, I took a deep breath in. And as I did, my arms, they seemed to rise from the railing, like they'd suddenly become weightless and unburdened. I could feel the edge of the concrete under the arches of my feet begin to shift. I started to pitch forward, and as I did, I felt the wind blow around my body and on my face and through my hair, and it felt free. Then an arm reached around my chest. A hand grabbed the back of my shirt. The man in the light brown jacket later told police that my body was completely limp when he grabbed me and he dragged me backward over the railing. Can suicide really be a choice if it's the only choice available? We ask ourselves, how can it be the only choice? How can it even be a rational choice? And hopefully we wonder and we ask ourselves how we can help. Well, we can start to help by better appreciating that our mental health is contingent on this state and the flexibility of our perceptions. Whether we have a mental illness or not, how expanded or how contracted our perception becomes impacts the choices that we make. When I was standing on that bridge, my perception was so collapsed that I only had that one choice. Now, when we encounter the suicide of somebody else, we always seem to try to rationalize it. I hear it all the time. And I think that's because we're uncomfortable with feeling helpless and with not understanding. But since we know that our perceptions are created and continually informed by our biology, by our psychology, and by our society, we actually have many entry points for potentially helping and better understanding suicide. One way that we can help is to stop saying that people commit suicide. People commit rape, they commit murder, but nobody has committed suicide in this country since the early 1970s when suicide was decriminalized. And that's because suicide is a public health concern, not a criminal one. And it's a health concern, we know that. 90% of people who die by suicide have a diagnosable and treatable mental illness at the time of their death. And we know that with medication, with psychotherapy, these treatments work. So we need to make these treatments more available in an informed way to everybody. And we can be a part of that change, whether we have a mental illness or not, by taking charge of our own mental health. When we go in for our annual physical, we make a point of doing an annual psychological too. At both the individual and the societal levels, we can challenge our old ideas, like that old idea of saying that people commit suicide. When I first started out doing this, I used to beg for somebody to do something about suicide and stigma. Well, that's not acceptable anymore. So instead, I've started doing something. When a leading cause of death among new mothers in the first year after childbirth is suicide, that's not acceptable either. When our First Nations, Inuit, and Métis communities are being ravaged by a suicide rate 5 to 6 times higher than the national average, that's not acceptable. When almost a quarter of 15 to 25-year-olds, who die at all, die by suicide, that is not acceptable. So like I said, when I used to plead for people to do something, and that's not acceptable either, well, you're here and you're doing something already because you're changing the way you think, and that's what changes the world. So for those of you who might be thinking about suicide today, good. Keep thinking about it. And then start talking about it. And then start doing something about it too. And for those of you who might be contemplating suicide, I know that there's a hope somewhere deep inside you. I felt it too. Keep that hope alive. We need you. We need you to be leaders in this conversation, whether we are ready to have it or not. And trust me, if you're anything like me, it's this conversation that's going to keep you alive every single day, as though you've got just one more day. Thank you.
Okay, hopefully everybody got something from that video. I personally found it very helpful when I was learning. So it gives you another perspective on how to think about suicide and mental health. So next we're going to go on to self-harm. So self-harm or self-injury means hurting yourself on purpose. One common method is cutting with a sharp object, but anytime someone deliberately hurts themselves is classified as self-harm. Other ways include scratching, burning, either with lit matches, cigarettes, or heated sharp objects such as knives, carving words or symbols on the skin, self-hitting, punching, or head-banging, piercing the skin with sharp objects, or inserting objects under the skin. The arms, legs, and front of the torso are the targets of majority of self-injury, but any area of the body may be used for self-injury. Self-harm is typically a harmful way for individuals to cope with emotional pain, intense anger, and frustration. And while self-injury may bring a momentary sense of calm and release of tension, it's usually followed by guilt and shame and the return of painful emotions. Next we have is substance use disorders. So that is by definition the repeated misuse of alcohol and or drugs often occur simultaneously in individuals with mental illnesses, usually to cope with overwhelming symptoms. Sleep disorders. So anxiety, depression, and other mental health conditions are often accompanied by sleep disorders that should also be addressed in treatment along with their mental health professional. Next is trigger warning. So a trigger warning is a statement at the start of a piece of writing, video, etc., alerting the reader or viewer to the fact that it contains potentially distressing material, often used to introduce a description of such content. You may see this on social media posts or in a video or movie that pertains or talks about specific mental illnesses or problems that could trigger reactions to those who are sensitive to the topic. Next is burnout. Burnout occurs when you feel overwhelmed, emotionally drained, and unable to meet constant demands, usually due to excessive and prolonged stress. And lastly, we have self-care, which is the practice of taking an active role in protecting one's own well-being and happiness, in particular during periods of stress. So we'll be talking more about this later on in the training. So that's it for week 1 of the training. So next week we'll be talking about therapy and counseling styles, the professional titles, the different psychologists, psychiatrists, or physicians, medications that go along with the therapies and counseling styles, boundaries, roles of the interpreter, and ethics, which those two will be presented by Robert. So thank you, and if there's any questions, also if there's any feedback, if any of you would like to voice out your opinion on how this interpreting presentation went, whether or not I answered everyone's questions, if everything is okay, or if it was informative, I would love to hear back.